Hello, I'm Dr. Helen Pinsanti, and welcome to Doctor. With me today is Dr. Bryn Henderson. Thank you, Doctor, for coming back. This has been quite a series that we've been doing. For those of you who have been watching week to week, I hope you've learned things. And today, we are going to be talking about sciatica. And before I start asking questions of Doctor, because I've got a list a mile long here for him, I would like to just tell you what I've been doing for the last 6 years is I have been what's called a locum. And what that is, after I closed my private office, I became what's called like a substitute teacher, only it's a substitute doctor, and I have been in every county in California. And I will tell you the statistics in the United States of America of sciatica is anywhere, they say, between 10 and 40%. I will tell you, I would say 50% of my patients had sciatica. Half of the patients that I saw in a day, and I would see anywhere between 25 and 30 patients a day, half of them had sciatica. So I know there's somebody watching who's been suffering, and we're going to teach you about it. We're going to address the problems. We're going to give you solutions that are natural to be healed and be finished with it in most cases, or at least help diminish. So Dr. Henderson, first question, what is sciatica?
Sciatic nerve is the largest nerve in the body. If you put your thumb up, that's the size of your sciatic nerve. Now, where does it originate? It originates in the lumbar spine, the low part of the back. And then there's multiple levels in the low back that combine each individual nerve to form roots from the branches that then congregate from the middle of our bottom to go down all the way to our toes. So if you follow that, there's a picture we can pop up here that shows you the various types of areas of the sciatic nerve. So there is a good picture. On the left shows the lumbar spine, and all these yellow branches combine to create this large yellow line that goes down the back of our leg and branches off into the knee area, the calf area, and the foot. And then you have the next picture over, which shows what part of the vertebra, okay, this particular picture shows the nerve as it's coming out between the bones, and that is an area that gets injured, and that requires then the body to fix it as it goes out from the backbone into the bottom and down the leg.
Should we go back to that first slide and he can continue? Yeah.
Okay,
So,
that's good, because then you can see in the second picture to the left, from the left, that the red area is an area that is inflamed because there's pressure on that nerve caused by the bone. Above that, where you can see the pelvis, is two red areas, and that is showing you that nerve is a compilation of multiple areas. It's not just one little teeny nerve, because here's all the picture below that shows you the bones in the low back, L5, 4, 3, and in each one of them, those red areas are inflammation along that nerve. All the way over to the right is a hot area that's very red, and it shows you compression of the bone on the nerve. And that is followed by a picture on the top that shows part of the disc herniating to the posterior area behind the bone in the middle of the picture.
All right. So somebody now is diagnosed with sciatica, and what has been the standard of care in medicine, say for the last 20 years before you before you started doing your
No, the evaluation is still pretty much, you better take a good history. You better make sure you understand what they can do and can't do. So range of motion of the legs and the body is pretty important. And then you end up in a situation where you want to know what they cannot do as much as what they can do. And pop them over on their tummies and start pushing on their back and seeing where it hurts the most. Nearly always, if it's sciatic, there's a major pattern to this that's easily determined. The nerves from the back all congregate into a band that comes out of the middle of your bottom. There is a muscle there called the piriformis muscle. It's in the shape of a triangle. And sometimes the nerve gets caught underneath that triangle and squished. So when there's a compression of that nerve, all nerves have two things. They have an axon. Let's say this pen's an axon, and that determines the motor function of that nerve. And then there's a sheath. It's like a sleeve that goes around it. And that determines pain, tingling, numbness, caloric, like hot and cold. And so this is called a sheath. In fact, it has a name, the myelin sheath. This is the axon. If the motor's working, their toes move, their ankle goes up and down, the motor's intact. So then you have pain. So that's on the sheath. But the sheath is unlike the axon. The conduction down the axon is continuous. It goes straight down that thing. But the conduction down the sheath jumps from node to node to node, like my knuckles, boom, 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 boom. So the myelin sheath, when that's damaged, you can have portions of it impaired where the rest of it is good. Not true with the axon. So most injuries are due to the sheath, and the compression is always on the outside before it's on the inside. And the conduction, when it's interrupted, you can feel it sort of skip areas of your leg.
Okay, so my question is how I was trained and other doctors, and someone comes in and we diagnose sciatica, we give them pain medicine. What do you do?
Well, we don't give them pain medicine. The first thing we do is figure out the position. In fact, you can go online and find piriformis exercises that gap that area, open it up to take the pressure off that nerve. So without spending a dime, you can have some relief. And just by dropping that knee out to the side, this way, you can gap the muscle in your bottom.
Oh.
So that's a pretty simple solution to see if it's easily fixed. Now, if you've been cooking with this for a decade, I doubt that a little maneuver like that's going to help you. But again, you go back to your history. What is the cause of this sciatic?
Okay.
And many times, especially in younger women, it could be childbirth.
Okay.
So then find the position where it doesn't hurt, get the massages going into that bottom. There's a whole industry built up around pelvic exercises. Mm-hmm. So using those exercises, you can absolutely impact that pain.
Okay.
Now, we're going to show you pretty soon the impact of this nerve.
Okay.
So as you talk about what do you do for it, that's what you asked, how do you heal it? Then if it's refractory, it means it doesn't respond to positioning and exercises and massages, then you should figure out what benefits this. Is it spasm? Should you give it anti-spasm medicine? I'm not opposed to that. But more often than not, you can get more duration, longer relief if you inject out, you don't inject the nerve, you bathe the nerve by injecting around it. Make sense?
Yeah.
So what we do often is you get a peptide or something like that and put in there that helps heal that nerve. If you can heal the nerve, then they're not going to be coming back off, and because there's damage to the nerve.
And so when you're saying damage, are you saying inflammation only, or
No.
what are all the types of damages
No
of a
question.
nerve?
Excellent question. Is it inflammation only? And the answer is no. That sheath, remember, can have pieces that are compressed. So if there's a lack of blood supply, then you're going to need new cells there, because those cells are dead.
Completely.
Well, if they haven't had a blood supply, what are we going to do? So what you have to do with any nerve is figure out where there's a lack of function. Is it the axon or is it the sheath? And if it is, it's like peripheral neuropathies, and we can get into those someday. This is the granddaddy of them all when it comes to peripheral neuropathies, because the sciatic nerve is so big. I mean, think about that. It's big as your thumb.
Yeah.
And so what you do next is you can get absolute relief sometimes with devices. So you get a transelectrical nerve stimulator, bzz, 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 heat, cold. In other words, these things don't cost much money. Are you kidding?
But by the time they come in to see me, it's always been, I've been in pain for 3 days, I can't stand it anymore, and they come to the doctor.
Okay, so you give them a shot in the tush and make sure it's not in the nerve, it's around it. Give them relief. And usually we back up to where the nerves come out, because this inflammation doesn't start in the middle of your bottom. Usually the inflammation starts in the low back. So you find out where it is, you inject it, you get it calmed down, and they'll have relief in hours. You can do that with some anti-inflammatories. That's what we usually use. And if you're going to use a pain reliever, in other words, it's better to usually to use a short term, not a long term. You don't want to introduce anything that's addictive. There's not a need. We can stop that with a peptide without any long-term consequences of addiction.
Prolo?
Yeah, well, Prolo is another alternative, but usually you'd wait to determine by ultrasound if there's a tear or any reason to bring those nerves, shorten them up or lengthen them. I mean, depends upon causation.
Okay.
Okay.
All right. And then my favorite question is, what comorbidities make sciatica
This
worse?
is your word today, isn't it? Comorbidity.
I just can't get over it in my mind that before 2020, nobody except people in medicine used the word comorbidity, and now it's in the language. It should be, you know how every year they say these are the new words that have come into
Webster
the language?
did that, yeah.
Comorbidities was 2020.
Okay,
sure.
that's fine. But now, thank heavens, we know what it is.
Yeah.
And the comorbidities of sciatic has to do with probably that last slide. Think of all the places that sciatic nerve feeds. Let's just start with the belly button, and we'll go down to the toes.
Okay.
So we're very clear, anything in that pelvis is fed by that sciatic nerve or a branch of it. So if you've got a branch of that sciatic nerve feeding the genitals, feeding constipation, i.e. the bowels, feeding urination, i.e. the urethra and everything, the ureters and up, there's a major impact. As soon as you have a change in function, they'll be in the office, because it doesn't take too long until whomever they're living with want that fixed. Do you agree with that?
Yeah.
Okay, so now as we're going down from the belly button, you could easily have changes in your prostate, you could have changes in your scrotum, you could have changes in your penis. All of those are fed.
Yeah.
So now you go into the into the rectal area, and constipation. We should do a show on constipation.
Oh, I'd love to.
Okay,
Yeah.
we can do that, and because it is fed by this nerve. It's not as big as the vagus, but it is a big one. So then you end up going into all the other pelvic illnesses that are mostly female in origin. They're huge. So you're asking an excellent question. What do you do? Depends upon cause.
Okay.
Now what is it causing? So the most common in that area is the pain that it goes down the leg.
Yeah.
Okay, do you agree with that?
Oh, I agree with that. They come in and they say, I'm feeling it down in my foot.
So what do they tell you that aggravates it? Driving the car, maybe? Because they're sitting on their tush?
Yeah.
How about when they flop their foot out and aggravate the nerve?
Yeah.
So you see people with foam pads on that side of their car seat so it doesn't aggravate that nerve.
What about long-haul truckers?
Yeah, the long-haul truckers have 3 H's.
Yeah.
Hypertension, hernias, and hemorrhoids.
Oh.
Did you know that?
No.
They all have those three.
The three.
3 H's are long haulers. But this would roll up there. See, they get fat. They get heavy. We could add a 4th H, heavy.
Yeah.
And that will push on that sciatic nerve.
Yeah.
And that's tough if you're a long haul.
All right, so let's say a patient comes in, they've had sciatica for 20 years,
20
comes
years.
and goes, comes and goes.
yeah.
Well, they haven't been to
that's
see
fine.
you.
Okay, comes and goes.
And they have a flare-up, and they're tired of these flare-ups. Is there anything you can do to lengthen the time in between the flare-ups?
Sure. Of course, not to sound redundant, but you've got to figure out the cause.
Okay, well, let's say you figured it out.
Okay, so then it's aggravating that nerve.
Yeah.
Okay, so what you want to do is back up to figuring out that cause and stopping it. And you can usually stop the inflammation pretty easy with peptides.
Okay.
And then you don't have to have any pills.
And in your, just kind of think through your years of practice dealing with sciatica, how many patients would you say failed with peptides and Prolo with sciatica?
Well, if you add manipulation and giving them exercises and changing their lifestyle, they don't fail.
There you go. There you go.
We have a blessing in that many patients come to us because they don't want to be on opiates and narcotics because
Right.
it causes constipation, which aggravates the sciatic nerve, because that's one of the branches, right? So we have had an aversion. This isn't recent. For many years, we try to use things that are not addictive.
Right.
As
I've never seen you write a prescription.
Well,
yet.
so far we haven't needed.
Right.
Okay. Now there could be a day I have no problems using them if that's the only thing I've got.
Yeah.
And probably, I do remember a guy, 85 or something years old, and he took it every morning to avoid a surgery. So God bless him. I have no problem with that.
Well, you mentioned constipation, so I'm going to switch over to it because it's something that is close to my heart. Not that
Close to your heart? Wrong end, girl. Wrong
I
end.
know. I mean, the compassion of my patients who are constipated. As I've told you, I've been in every county in California being a substitute doctor. And I would say out of the 25 or 30 patients a day that I saw, half of them were on 20 medications. We're talking about hypertensive medications, maybe 2, 3. We're talking about cardiac AFib, medications or not, any other thing. We're talking about diabetic medications. They might be on 3 of those. So we got 3, 6, 9 already, and we've only hit 3 diseases. And then they have, maybe they have something else. I can't even remember the diseases now. You can help
arthritis.
me. Arthritis and sciatica and this and that and the other. And they'd be on 20 medications. And I think, well, just 20 medications alone are going to kill you, But here they are. Doctor, please give me something. I haven't gone to the bathroom for a week. Please give me something. And you say, all right, how about Colace? I'm on that. How about we'll give you something like a laxative.
How about dynamite?
They would like that. They would like that.
Okay, here's the deal. There's a process in us that moves the digestive process, moves the food from mastication, from chewing, to absorbing in the tummy, going through the various type of small intestinal to the large intestine. Then the large intestine is responsible for taking out the fluids or keeping the fluids in. So when that goes gangbuster, you're going to be constipated real fast because it's taking out all the fluids, right? It's sucking them all back in.
So first thing is drink more water.
That's right. Dehydration is your nemesis. You better be drinking a lot of water.
Yeah.
And the second thing is what you eat, because if it's going through lickety-split, you're missing your fiber. You've got to have fiber. Now, I don't care if you're eating mangoes or you're eating oatmeal. Doesn't matter to me, but you need fiber.
Okay.
The third thing that you're going to have to do is you're going to have to move. You can't just sit on your tush.
Yeah.
Sedentary people in a nursing home have more constipation because they don't move.
Okay.
Okay? And you post-op too. Post-operative, you need to move this knee up to your chest about 100 times a day to settle everything down in the pelvis and get things cooking. Because otherwise it's just sitting still.
Yeah.
The fourth thing that will happen all the time is you can't let those toxins sit in your body.
Right. And I want to jump in here because this is my favorite thing to tell people is that we have something called a splenic flexure. That's where the transverse colon hits the part that becomes the descending colon. And if you go on your first urge to have a bowel movement, if you get up, go to the bathroom, that will eliminate everything up to that splenic flexure area. If you wait to the second urge, you're down to 50%. If you wait to the third urge, you're down 10%. So what happens? You've gone on the third urge, you've only taken 10% out, you have 90% of your waste material sitting in your colon. Not good.
Horrible.
Yeah.
So what happens when you have all that toxin in you? Where do they go?
To your breath, to your,
for sure.
for sure, to all pimples. Acne, not necessarily acne, but bad
and those
skin.
are both external.
Yeah.
So what does it do internally? So is there a hemostasis in our colon that we need to preserve as well? Is there an acid-base balance in our bodies? Are you screwing up the body's ability to eliminate it because you're not listening to your body?
Yes.
Okay, that's
Yes,
the answer.
that's
isn't it?
the answer. You're not listening to your body.
So if it sat there too many days, you're sort of out of luck. Let's call shit out of luck. But you don't say that. You're out of luck.
Right.
So what you have to do is get an enema, or you got to get that plug out of there.
So you're recommending an enema?
Not well. If it's gone 3-4 days and you haven't had a bowel movement, I'm telling you that no matter what, you better get the feces out of there.
Yeah. So enemas, suppositories.
I would start with the least invasive first.
What's that?
Well, it's probably top down is better than bottom up. So you can do what you do with liver disease. You give them lactulose or something that stimulates it from the top down.
Okay.
If that doesn't work, then you get the suppositories cooking.
Okay.
And then if that doesn't work, you're probably last resort on an ambulatory and outpatient basis would be an enema. There's fleets and other enemas you can buy OTC over the counter that they sometimes are abused, okay, just like laxatives are abused.
Yeah.
In fact, there's a diagnosis of a laxative abuse because all the muscles are now mushy because they've lost their need to
move,
to squish the stuff forward.
Oh.
So laxative abuse is common.
What can they use? What can they do to get those muscles back?
Well, there's 2 or 3 things. One, you start with a hydration.
Yeah.
And 2, start with the exercise.
Fiber.
I mean, and fiber. Most women have been exposed to Kegel exercises, Kegel. That's where you tighten your bottom and you let it go. Tighten and let it go. Anybody who's delivered babies knows that it's good to have strong pelvic muscles. We all should be tight in that. In fact, they smile at each other at the stop signs, right? Or the red lights, just doing their 10 Kegels every time. So that is a good habit to get all of us doing. You need to have that movement, especially if you're sedentary. Obesity means that you're pushing against the mass of your tummy into your pelvis, right? It's like having that watermelon in there. That's going to be tough. So as you're moving, this stool, and remember it's toxic waste.
Yeah.
You got to get that out.
All right, so my brain has now jumped to BPC 157 because that is for muscles.
And it helps GI.
And could a patient who's now taken laxatives or taken things and lost the muscle ability to move it forward, can they get a shot of that and be helped?
Absolutely. BPC 157, one of the indications is colitis and other problems with the colon. So it has two functions, one's muscle and one's colon. So it's a very good selection on the peptide. So you've probably seen that before in our office because that is a double whammy. You have one shot that does two functions.
So a person with colitis could come, who's been suffering, could come in and have a shot and their own body will heal itself.
I have personally given people with ulcerative and Crohn's, ulcerative colitis, an injection of BPC 157, and within 3 hours, it decreases all their pain, all of it, and gives them an immediate relief. Now, does it last forever? No, but that is a unbelievable.
Yeah, it's a sad disease.
Yeah, and it really effectuates a relief that then they can get ahead of with the other medications and habits, bowel habits they should have.
Yeah.
Nearly all these are genetic in origin, and you have to get them on a routine, the hydration, the exercise, all that craziness we just talked about. But BPC 157 is an excellent choice to begin getting normality back in your bowel habit.
What other peptide do you like for constipation?
Well, again, a lot depends upon what causation.
I'm just talking about those ones that have lost that ability.
I like them. Then get into the muscles, and the mitochondria work good too. There, anti-aging and mitochondrial BPC of the peptides to enhance the mitochondria. The energy of the colon will help too.
Well, this has been quite a show. I hope you've learned a lot. I've even learned a lot. And I thank you, Doctor, for being with us. It's been very informative. Just to remind you, we are doing a weekly show with Dr. Henderson. We're trying to do a series on Doctor to Doctor with him. And we encourage you, if you need a new primary care physician, please feel free to call doctor's office and we'll get you in. And we're happy to help you with all sorts of pathologies and things that have gone wrong in your body. We talked about today constipation, we talked about back pain, and I hope you learned something, and we look forward to meeting you in person. Thank you.